Department of Health.
Good afternoon, everyone. I just wanted to share that I just received notice that Virginia has been one of 6 recipients to receive awards from the CDC for the Sickle Cell Data Collection Project. Yes.
It's only taken 2 years.
So this project will allow Virginia as well as the other recipients to work with CDC for us to combine some of our state agency data information from newborn screening, vital records, hospital admission, to get a better picture of what sickle cell disease looks like in Virginia, to be able to show trends and provide that information to the community so we can help make better healthcare and policy decisions here in Virginia. There are other, like I said, there were 7 awardees. Some of them are represented here at the conference today, but I won't steal the thunder. I do have the list, but I don't want to steal the thunder of the other states and have their contact people let them know. There were supposed to be 5, but they awarded 7. So we're really excited here in Virginia, as well as for the other recipients as well, to be a part of this next cohort of the Sickle Cell Data Collection Project. So.
That's wonderful. Congratulations. Congratulations. That is so neat. Okay. Hopefully everybody else will wander in. I think we're missing a few. Welcome back from lunch. Hopefully that was a stimulating morning of discussion and information sharing. Certainly was for me, and I certainly enjoyed being at lunch too. In your spiral notebook, I just wanted to call attention to you there are a couple of documents in there that I'm not sure you may have found yet because they're pretty deep in there, but there's a relationship to the healthy lifestyle. There's the CDC, actually it's a booklet on self-care, wonderful resource, and I know many of you probably already very familiar with that, so I do not mean to offend you, but for those of you that may not have found that, it's certainly there for you, and you can use it because it's public domain. It's from CDC and they want you to use it, okay? So, all right. Thank you, Dr. Smith. Did y'all get that? How many of you have ever seen it or used it? Some of you? Okay, well, those of you that have not, please, you've got a copy of it, a hard copy, and then you can get it online easily. It's on there. You just download it and use whatever. It's a wonderful resource, and we've used it in many different ways. I have in my career here in Virginia. All right, this afternoon we're going to kick off our afternoon with a panel, which I think you're going to find very interesting. And now that you don't know Shirley, I'm going to introduce to you Shirley Johnson. Okay. Shirley actually she's a licensed social worker. She's been in business over 20 years, which she looks too young to be that. She has worked in mental health, child health, individuals with disabilities, and 10 years of experience in advocacy and care for patients with sickle cell disease. I didn't realize it had been 10 years since you've been around, because I remember when Shirley came to work with our transition program. She's been developing a foundation-funded transition program at VCU for patients. She's published on that, and you can look her up because it's great what she's been doing there. She's worked on the research grant that we've mentioned a couple times that we've been working together in the last few years since 2012. She has several publications. I'm not going to get into all of those, but you can certainly look on our resource list. They are listed there so that you can go find them. She also is managing the sickle cell disease patient-centered medical home that was approved and initiated at VCU in January of 2018. Therefore, that's where we are now. I'm going to turn the podium over to Shirley to facilitate our panel, and I think you've already met most everyone here, but to make sure you recognize who's going to be here and share with us. Thank you.
So I think it's really important that my team sits up here and suffers while I go through some of my presentations. So they're going to sit up here and you can take great pictures of them. I'm very proud to be associated with everybody that's up here. This is not a one-person show by any sense of the means to get the job done that we've been doing, and each person here has provided their own expertise and their own skill set to make the job work well. But before we get started on introducing you to them and all the things that they can contribute to the program today, we did want to present to you a short story of one of our patients who is here today with Dr. Lopato, and let you kind of get an idea of what it's like for the patient when they're going through an exam with the physician and maybe some of the questions that he or she might ask.
So how long have you been coming to the sickle cell clinic?
Ever since I was a young girl, my mom used to bring me as a child.
Okay. And you used to come to the pediatric clinic,
Yes,
and now you're in the adult clinic.
correct.
Okay. And tell me what your experience has been when you get admitted into a hospital that doesn't have a comprehensive sickle cell clinic.
It's very frustrating going to a hospital that doesn't really have the knowledge of dealing with patients with sickle cell, because oftentimes they feel as if you're there just for the pain meds and not really trying to give you the treatment that you need to get better. So it becomes frustrating and stressful and adds more onto your crisis that you're already having.
Okay. And how do they manage your pain when you're in that setting? As far as how quickly are you able to get your pain medication?
Sometimes it's difficult to get it quick in a setting where they don't really know a lot about sickle cell, because they try to figure out what type of meds to give you to get the pain under control quicker. And you have to kind of tell them what to do to help them out of the system, and that's difficult to do when you're in a crisis.
Okay. And when you do tell them, or try to give them some advice on how you've been treated in the past, is that receptive positively?
No. Because I guess they feel as if you're telling them how to do their job, and it's, they don't like that.
And when you do come to a clinic that really is dedicated to sickle cell disease and the care of those patients, what are the things that you look for? What are the things that you like in the ideal clinic?
Coming to somewhere where the staff is knowledgeable about sickle cell and knows exactly what needs to be done to cater to that particular patient needs. Because I feel each sickle cell patient is different when it comes to what pain meds they need, or what kind of regimen they need to be on in order to function daily. And dealing with a staff that understands that and know that it makes things a lot easier.
Okay. And how often do you come to this clinic?
About every 3 months.
Every 3 months.
Yeah.
And when was the last time you were admitted in this hospital? Has it been a while ago?
Yes, it's been a while ago.
Okay.
Yeah, maybe about 4 or 5 months ago.
Okay. What other things specifically would you want in a sickle cell clinic that would make it like the most ideal place? Are there any other things?
Maybe like in the waiting area, information brochures for like family members that may come in, that bring you to your appointment, or for people that's in past and going to other clinics if they're curious about what sickle cell is about. Just information that they can pick up and gain knowledge about what sickle cell actually is about.
Okay. And in the clinics that you go to, whether it's when you're a child, do these clinics foster a community among the patients where you're able to meet other patients with your disease and learn how they cope with their disease?
I saw that more as when I was younger, but in an adult clinic, it's kind of like you don't want to invade people's privacy and ask, okay, are you here for the sickle cell clinic? But when I was younger, I know going to the clinic, I would hear my mom talk to the other parents about things they did to help their children out, or what they could do different to assist their children when it comes to pain crisis and stuff.
Okay. One of the things that we are developing in our clinic is an infusion clinic on the outpatient side where patients can come and get pain medications if they're having a crisis. Is that a service that you could see yourself using? Is that a service that you think would be beneficial?
Yes, very beneficial, because sometimes having pain crisis, you don't necessarily want to go and have to deal with everything that's going on in the ER.
Okay.
And having that here in the clinic, somewhere where you're comfortable with being already,
Okay.
I feel it'll be a benefit.
Okay.
There's our star back there. It's not easy for someone to come and videotape your story, so we were very appreciative. And as you can see, she was very honest about how great things are in pediatrics. And even though we feel we've made some great strides in the adult clinic, we're still not at a place where patients feel like they have a social acceptance maybe by all the staff that come in. They don't have an engagement with other patients and able to exchange information. So these are things that we're going to continue to work on, and we really appreciate you providing your feedback. So as we lead into the medical home, I really felt it was important to talk a little bit about how we got here in a little bit more detail and why we feel our mission is so important. And one of the things that was really important to our team is that we tried to take a patient-centered approach when we were dealing with our patients. We know that many times we think we know what's in your best interest, but obviously we don't always know what you want. And so there's sometimes a little bit of a distinction. I mean, I think the navigators really try to be the real true advocates to the mission of the patient. And sometimes we as either behavioral health specialists or clinical people have different opinions, and not all of them are focused around the patient-centered approach. So you could see that, you know, I came from Ohio, and back where I worked with individuals with mental intellectual disabilities, this was really prominent 15 years ago. And so it's funny that we're really kind of just getting into that place here in our practice. So I think we're a little bit behind the times, but we're trying to catch up. And it's really important for the healthcare system's mission to really look at the values, the leadership, and the quality improvement that drives a patient-centered approach. We have felt that with the medical home, we've been able to achieve some of that. And the fact that we do meet as a team, and the fact that we also make sure our patients know that we meet as a team, helps, I think, bring that patient-centered encompass together. And like I will probably say more than one time, the navigators really try to bring that to our attention each week when we meet. We feel it's the right time and the right place. You know, healthcare is changing. Not all of it's changing for the best, but what we're trying to do is, you know, when you're looking at a healthcare institution, yes, patient quality care is very important, but they also want to reduce costs to the institution, especially not really knowing the future of the Affordable Care Act and how that's going to impact healthcare systems. And we do like to have patients and families involved. We try to respect your cultural differences, maybe to what we think is important, the values that you have as a family, as an individual, and we really try to also be aware of your socioeconomic situation, because not everybody has the means to do the things that we all think we could do or should do. So, like I said earlier, this is a repeat, my apologies. Patients and their families are really expected to be part of this program. So in transition, I believe it was India who had mentioned this. When we had first started, we made this really great idea that, you know what, when patients turn 18, they need to just come to their first appointment by themselves. Absolute disaster, like she said, with an exclamation point. And now we feel that it's really important for patients and their families, if the patients do want the families involved, to be part of that decision-making process. Because sometimes when you're ill and you're not feeling well, you want to have an advocate there for you. So your best advocate is the people that love and care about you the most. So we do try to take that patient-centered family approach. And we also try to encourage the patient to have the families at the facilities with them whenever is possible, especially if we feel that maybe there's a literacy issue, maybe there's a cognitive impairment, maybe the patient's really not understanding what the physician is saying, or maybe they're just emotional and they're not feeling well that day and they may misinterpret something. It's always good to try to have another voice there. Not that the navigators can't be that voice, but it's also important for their family to be there. And we also try to be transparent. And sometimes what we have to say, somebody doesn't want to hear, but I think it's really important too to be honest with the patient and let them know some of our frustrations, some of our fears, some of the concerns we have about some of the behaviors that we're seeing, and being able to give them all the information they need, including a copy of the labs that they need, their individual service plan, so that they can then in turn be empowered to go out and advocate for themselves. So there's many different versions of what patient-centered care is, and I think that the core values are represented here, which is really, again, kind of, going ahead and reconfirming what I had just said, is looking at values and social cultures and making sure we're being respectful of them, making sure we're providing them information and education, not only about sickle cell disease, but for example, if you're going off to community college or a vocational rehab program or your insurance, or all these other things that come into play with adult care that you don't necessarily have to deal with in a pediatric setting. Being there for them. Maybe again, it's not always what they want to hear, but you're providing them emotional support and trying to relieve any anxieties or fears that they may have, especially if they become really ill and they're worried about whether or not they're going to make it through this next crisis. Again, involving family and friends. Transition is very important. So some of these things that we've already been talking about most of today, and of course access to care, which we're very fortunate here in central Richmond, but if you go out to rural areas of Virginia, they don't have that access to care. And some of you could also, tell your stories about how you may not have access to care. So we try to make sure that if they cannot come here, that we somehow have individual treatment plans or a way of connecting with the facilities where they're going so they can try to give them the best care that they can. And any patient that's here in the room, I'm sure you have your horror stories of when you've gone to facilities you do not know how to take care of sickle cell patient and what your experiences have been there. And I think I don't want to kind of continue to, rehash some of the same things we've been talking about, but obviously, it's an individual health care plan. We want to make sure that each person is treated individually and that we try to make sure that they have allocations and the resources that they need. So I was asked before we led into the medical home to talk about care coordination, and I went back and I did some literature review, and I found this pretty interesting, and I probably haven't thought about this in this context for a while. But apparently, well, not apparently, there is a difference between care coordination and case management services. And depending on what your facility offers, some of you may be getting care coordination and others may be getting case management. So in the literature, they're talking about the fact that primary care physicians and all medical personnel should be able to provide coordinated care. It is not case management because most of the time they don't have the resources or the abilities to go out there and find your insurance company or your trip to the Social Security office, but they can help you pull together maybe if you need home health or if you need to go get a chest x-ray or if you need something that's kind of related to your medical care. They're expected to be able to provide you that care coordination. The AHRQ emphasizes that care coordination necessitates commuting at the right time to the right people, as well as investing in tools to assist them more effectively towards specific and immediate needs. So if you think about yourself as a health navigator or as a case manager, you know you're really stepping out of those boundaries. So that really looks back to your nurse practitioner, your physician, kind of taking the rein and doing some of those things for the patients. And again, I'm not going to go ahead and read this to you because you're capable of reading it on your own, but the Case Management Society of America actually has a different ideology about what they believe case management is. And that is what our navigator team, our clinical social worker in some cases, and other members of our team do on a daily basis. And probably some of you that are in the profession do the same. If you're talking about your nurse may be providing you some type of care that you need and getting you the referrals and stuff, but boy, that nurse really needs that social worker to jump in there and do hands-on work and get the job done that they just don't have the time, or not necessarily the skill set, but they just don't have the time or the resources or the knowledge to know where to go find things. I did a phone call recently with somebody from another site, and they had not worked with sickle cell patients, and they had asked me, what are the barriers that you think you're going to face? Well, here I am, I'm talking to this seasoned social worker. I'm thinking to myself, geez, why doesn't she understand what some of the barriers are that, you would be dealing with sickle cell patients? Well, her exposure had been in the pediatric department. So now she was working with the adult sickle cell population, and she honestly did not understand all the barriers about transportation, maybe about prior authorizations for your medications. And as I'm going through this with her, I'm thinking, geez, this is a seasoned social worker who's been in the program for a long time, and she still doesn't know all the things that she needs to know to help the adult patients. So sometimes we have to take a step back ourselves and realize it's a learning process. Not everybody knows that information up front. Some people are new to sickle cell disease, so you want to be able to give them the opportunity to learn the disease as well as the resources that they have. And always be there as a team member to be able to support them so that they could go ahead and provide the case management services down the road that they need to for their patients. So there's 4 components to care coordination. And again, we've kind of touched on these, I think, throughout the last day and a half, and I'm just going to kind of go over those quickly. But of course, ultimately, we want a patient to be satisfied with their care. We want to make sure that the family feels that they are satisfied with the care that they received here, and if they are not, what they can do to change that. We want to make sure that if we've missed something, like scheduling them a follow-up appointment, that maybe in the future, the family member or the patient might give us a reminder, and we want to make sure that we do those things before they leave the clinic appointment or they leave the hospital. And of course, we always want to make sure that they're satisfied with us as best as they can. I'm sure Micah can tell you more horror stories than I can, but she's not always they don't always want to see Micah. So Micah may not actually be somebody that is doing bad things for them, but they're not wanting to hear what she has to say. So we try to kind of balance those things and make sure that everybody kind of has their needs met, both the staff and the patient. Of course, we also want to have you be able to function in the job that you have. And again, this is not, I'm not going to go back and repeat what I just said earlier, but we want to make sure you have resources, know how to access those, making sure that you have the team members or the support that you need from other individuals that you may be working with, but sometimes you're out there on your own. So you need to know how to go out there, you need how to do research, you need to know how to ask questions. I did that a lot. When I came here, I knew nothing about sickle cell disease. I was in charge of running a transition program. I didn't even know what that was. So I'm calling around the country, and I'm talking to people in Oklahoma, and I'm talking to people in Detroit, and I'm talking to people in Houston, and I'm like, oh my gosh, there's like all kinds of different things. So sometimes you just have to be willing to step outside your comfort zone, pick up the phone, or go walk across the street and talk to somebody and find out what you need to know. Of course, the clinical care, we talked about this as well. We want to make sure that there's adequate communication going on between you and your provider. Again, coming back to the patient-centered approach, it is your body, it is your life. You should have a right to ask questions and be able to get the answers that you are hopefully seeking when you're talking to your clinical provider. We do know that physicians have they talk at sometimes a different level than what most of us can understand. I am not a medical person. Sometimes I don't understand what they're saying. 10 years down the road, I'll still be saying, what are you talking about? Can you kind of explain that to me a little bit? So be able to go to your doctor and ask them those questions. They're not going to be, hopefully, I think sickle cell providers would not be offended, but I can't speak for all doctors. But ask them the questions. I don't exactly know what you mean. What is my hemoglobin level? Why don't I understand what that level is supposed to be? What do you mean I might be having acute chest? What exactly are those things? What do you mean my gallbladder is not functioning properly? So make sure you maybe go in with your notes when you're going in to see a provider. Make sure you feel comfortable asking the questions. And you know what? They're trying to get you in and out of there because their clock is is turning, but go in there planned. You know, give them the time to ask you the questions that you need, and then you in turn take time and say, you know, this is really important to me. I need you to take 5 more minutes. This is my body, my life. I need you to explain something to me that I don't understand. And then, of course, the cost of care. One of the big reasons why we have this program is because the average cost of the VCU health system for sickle cell patients was about $6 million a year. And the reason why it was that much money is because on the adult side, we did not have the resources that we've been begging for 20-some years that Dr. Smith has been here. Him and I were a 2-man show along with the old nurse practitioner there for the longest time, and then Daniel came and joined our team, and eventually after we let them know how important the navigators were, we were able to get them to actually fund this program. But before that time, return ED visits, length of stays were 3 and 4 weeks when they should have been 3 and 4 days. We couldn't get patients to stay out of the hospital. So, you know, we finally were able to tell the health institution, this is your problem. You're not giving us the things that we need. They have them in pediatrics, all of a sudden they come over to the adult side, we don't have anything for them. And most of the time, that's when all of your health issues take place. You're having vocational or educational issues, you might be having family issues. You had nobody to really reach out and help you with that. So this is just a brief slide of when we did our first initial presentation, the things that we asked for. It was funny when we went in here because we were told not to ask for all these things. And they said 3 times over 2 years. And the biggest thing that they told us not to ask for was Daniel Sopp's position. And they were basically saying, the health system is going to come in and save you. We're going to let you know all the things that you need to know to crunch your numbers and be able to do all the things that you do. That was so wrong. They didn't do any of those things. So Daniel has a job description that really isn't his job description. So now that he is like moving on to more research and getting his PhD, we've been able to convince them that we actually do need a Daniel full-time. And after 2 years, we have been able to get this position. But we went in there, we let them know that we needed that inpatient nurse practitioner. You couldn't have somebody on the outpatient setting managing patients in a clinic as well as trying to go and see them in the hospital. So here they were laying there for 3 or 4 weeks. They weren't getting the things done that they needed to get done. Then they would be discharged, didn't have their appointment for follow-up, didn't maybe have rides to their appointments. Maybe their insurance wasn't, valid, or they had some issues with insurance, so they weren't coming in for their clinic care because they couldn't afford to pay for it. We now have that system in place. And what we did is after they told us, yes, you could have the money, then we tried to figure out exactly how do we make this work. So I was really not familiar with this process. Does anybody know what DMAIC is? Or is anybody familiar with the DMAIC process? Okay, so it's a really great process, actually. It teaches you how to really address these 5 issues as you're going through your planning stages. So the first thing we did is we brought a team of quality improvement people in from our healthcare system side. They were gracious enough to help us put the proposal together, and then they really wanted to be part of that proposal as we move forward. And they come walking in, and they have their big sheets of white paper, and they have all these sticky notes, and they have their Sharpies, and they're putting all this paper up in what we now call our war room, and we basically threw darts at it and said, what is everything that you think you want to have in this program? I guess that's how we defined it. So then we started, what happened to it? So then we went into our, hello? Oh, well, I guess we're not going to do that. So then we went into our measure process, where once we defined what was a now, which was the first 6 months of our program, what was later, which was our 6 to 12 months of our program, and then what was our latest was past 1 year, what we wanted to focus on. And we developed some processes, and we hired personnel, and we put some of those things into place.
Shirley, let me interrupt right there. We spent a lot of time figuring that out. Can you imagine that there was disagreement in the room? Disagreement in the room about what we should do first. And it was a classic thing of, 5 blind men killing an elephant. And everybody thought, well, this is clearly the most important thing to do first. Everybody wanted their thing to be the
Yeah, the walls have stories to tell. I hate to say that, but it was always the most appropriate language that might have been used while we were in there as well. This? Okay. Yes. Okay. So then after we did our defining and our measuring, then we had to realize, how do we analyze this? I'll have Daniel really talk to you more about that because that was really his job. And then we decided how we wanted to continue to improve on what we have. And I'd say right now we're still in an improve area for some of the things that we're doing, and then we're in a maintaining period for some of the other things. Like, I kind of feel, and Marla and Stephanie could maybe say something differently, but I feel the navigators have a very good understanding of what their roles are. They come in, they know what their expectations are. We might change some things here and there. Sometimes they like it, sometimes they don't. And we try to talk it out. But I feel that there's some things that are really pretty much moving in the right direction. And then, of course, there's other things that we still have to work on. One of the things is going to be the infusion center that we're trying to put into place. And you talk about a war room. That's even a worse war room than what we went to when we got the medical home. So these are a series of what they call Lean Six Sigma processes that if you're trying to present something to an organization, you want to start with defining the problem and working your way down. And hopefully the success of what you're going to have is a result of the professional people that are standing up here. And like I said, I can't say it enough, but we would not be in this position if we did not have them. And each one of them contributed to everything of the success we had last year. I said it, I think yesterday, we saved $1.4 million to the healthcare system last year, improved patients' quality of care, as well as tried to keep them from coming into the emergency room and living a better quality of life. And for that, I would like to go back and introduce you to our team. So you've met Dr. Smith and Dr. Lopato. They've talked for about the last day and a half on their area of expertise. And I don't know, Dr. Smith, is there anything else you would like to add? And in my job, I just want to say that it's not always the happiest job. You know, being in middle management has a lot to be desired. And you get battle scars no matter who you're dealing with. You can't make everybody happy up here. You can't make everybody happy down here. But I think what has really made the job the most enlightening to me is, again, the people that are sitting up here. And they're independent workers, they're thinkers. They come to me when they have a problem. We talk it out. I have an open door policy. Very rarely do you see my door closed. And I would like to think that I've gone to bat for them a couple times. And as a result of that, I believe there's a mutual respect about the job that we have. And they let me go out and do all the dirty work while they have to go out and take care of the patients. So they have probably a better job than I do some days. And then I would like to go ahead and reintroduce Daniel. He's going to tell you a little bit about what he does every day, because if you want to go ahead and replicate this program, you definitely need to know about data. So Daniel?
Oh, is it now?
Yes.
Oh.
This is your 5-minute version.
Okay, I wasn't expecting it to be now. Okay, so data, wow. With the Sigma Medical Home, as you all know, the question or the problem that the hospital was trying to solve was money. They cared about money. The problem that clinicians want to solve is quality of care. They care about what they can do that can consistently make the patient better. So everybody, when everybody came to me, the administration said, show me where we're wasting the most money. Show me what we can do to save that money. The clinician says, show me where the patients are not doing well. Show me what we can do to improve those processes and improve outcomes. And on that perspective, because of that, we measured everything. We measured length of stay for patients. We measured patient-related outcomes. We had a lot of surveys that patients filled out prior to having their care done in the clinic, inpatient when they were seeing Micah, when they saw Caitlin. We measured vitals at some point. We measured, we got blood results that we kept track of for a certain period of time. But the impact on the hospital side or the system side was really related to length of stay, readmission rate, total number of days spent in the hospital by every individual patient. And those are the key metrics really that drove it home and allowed for the hospital to be able to support us. So no matter what you do for a sickle cell medical home or any medical home for that matter, you got to be able to show what the progress is when it comes to a patient's utilization behavior of the system, whether it's in an emergency room, it's inpatient. You got to be able to show how much money they cost and how much money the healthcare can bear to support versus not. Processes-wise, we also try to measure, and we're still working on improving those metrics, how much time a staff member or a patient navigator spends with a patient to be able to lead to a positive outcome or not. You know, to just essentially try to improve processes over time. Is it okay to have one person spend, I don't know, out of an 8 hours work day, 7 hours dealing with one patient? Is that productive? Is that going to lead to a positive outcome? Those type of metrics were the metrics that we also focused on an operational perspective. And I think that's about it, unless anybody has any question. During the proposal time, we went back 5 years, and we looked at pattern in order to be able to show what the projected savings would be and what the projected impact would be. Yes.
This might be a somewhat naive question, but don't hospitals want people to stay in them?
Good question. Good, very, very good question. So, hospitals want you to stay for a certain amount of time during which they can make the most amount of money from your insurance provider. Once you hit, and different insurance providers have different thresholds. Once you hit that threshold, it starts costing them money. Yeah, and they don't necessarily want to kick you out either, even if you, because they can get a certain amount of money from you, so they want to kick you out if they can fill the bed back with somebody else that has a high-paying insurance.
So, getting specific, in Virginia, you're allowed 21 inpatient days if you have Medicaid. On the 22nd day, the hospital is not likely to come back. If you do come more, the hospital is going to look to do something, but their losses, because they're no longer getting paid. So we had to show the hospital how we were cutting their losses on Medicaid and indigent care patients who have no insurance whatsoever. If you have Medicare, you get paid according to the admission under something called a diagnostic related group. That means you get a certain amount of money, which calculates that you're going to be in a hospital for an average number of days. Well, guess what? Once you go past an average number of days and the hospital feels that they're spending more money than they would get for that DRG, the hospital is likely gone from that admission. It'd be okay, come back, but you need to go home. And so forth and so on. If you have Anthem Blue Cross Blue Shield, it's all about the Benjamins. It's just, you know, the more stuff we do, the more we admit you, the better.
Yeah.
And is that whether you're getting better or worse or
Yes.
what?
Doesn't matter.
That's the right answer.
Yeah.
Whether you're getting better or worse, from a pure economic point of view, if you have Blue Cross Blue Shield, it's all about what that insurance company will accept and pay for. If they will accept it and pay for it, the hospital would love the privilege of having you there. They'll serve lobster or anything else.
What about the Medicaid patients?
Nope.
That 21 days, if you're not getting better,
You
in
can right up to that 21 days, you're good.
They're not gonna kick you out, but they're gonna want you.
That's true. That's true. Yeah.
21 per year.
Go ahead.
Wasn't there something that has to be block and change for a policy that was
Within 30 days.
30 days, good.
So now you're referring to the CMS
30
paid
days.
for performance program. I wasn't gonna go there. So CMS decided in its infinite wisdom that for Medicare patients, they would pay you for performing better on certain diagnoses, meeting certain quality criteria, and so on. If you meet those criteria, you get extra money. If you don't, as a hospital, you get penalized. Hospitals do not want to get penalized, so they pay big money to their staff to make sure that everybody checks the quality boxes that they need to check, so they get their pay for performance money. It gets worse. But that's what pay for performance is.
Anyone else? All right.
So Taylor Elliott is our clinical social worker, and she's told you a little bit about her role, but I want to let you know how important we felt that this particular position was. When we recognized for a long time that therapeutic intervention was really critical to the care of our patients. Taylor went into the depression, the anxiety, sometimes the opioid misuse issues, and any other personal trauma that a patient may have suffered. But we did not actually have a dedicated therapeutic program. And we really fought for this position for the fact that although it's going to take a long time to get patients to be accepting of counseling services, mental health services, behavioral health services, whatever the word is that you want to use, we also know that it's very important. And I think she also had gone into the fact that many times patients don't even realize, just like maybe we don't, that we're suffering from something and that we need a mutual or an impartial person to kind of give us some guidance and some suggestions. We're not going to get into all the stigma and the biases because we'll get into that a little bit more tomorrow, but this role was really critical. It's taken time to even get to where we're at today, and we have a long way to go. So I'd like Taylor to maybe just give a little bit of more feedback about maybe some of the things she's experienced and some of the things that she would like to happen with the program as it moves forward. Taylor.
Hello again. So things that I have experienced coming into this role. Patients don't want to talk about feelings. So yeah, it's acceptable to talk about anger, particularly when you're inpatient or ED and providers aren't taking care of you like you feel like they should be taking care of you. But when it comes to kind of more of those hardcore topics of not wanting to wake up in the morning, feeling like it'd just be better if maybe you didn't wake up at all, dealing with the social anxiety of feeling like you want to talk to somebody, but that every time you reach out, they're going to hate you for it. So patients have a lot of difficulty opening up to strangers. And so when I mean that is I'm a stranger to them, particularly when I came in too. And I mentioned it a little bit earlier, you know, white social worker coming in, CPS, what are you doing here? I'm not CPS. And then just trying to, you know, let them know that I'm there for them. But then they're like, well, how do I know you're there for me? I just met you. And so oftentimes case management is the best way to build rapport. But then as we get into later is the bulk of that work is done by the patient navigators. And so that leads to where, how do we end up balancing to where I can still be there for them and show that I'm there for them and not just be another person coming in and wake them up in the morning and ask them a bunch of questions. And so that does take time. And I know earlier we had a little conversation about building rapport, and part of it is just listening, believing them, validating their experiences, and also helping them to connect to other people who may have similar experiences or resources where they can have a means of having a more trusted person being able to talk to about it. And just because they have rejected talking to me the first time doesn't mean something may happen situational where they see me with another patient and meeting with them and say, oh, she actually goes and talks to these patients and they talk back to her. Maybe I should see what she's about. And I forget the later part.
Maybe the future.
The future. So I think it would be good to have, not that we don't already have designated clinic time, but having a bulk where not only do we go out in the community, but that we create an environment where patients can feel welcomed coming into and speaking with somebody. So right now, some of the interventions I do in clinic are in the provider rooms, which are sterile, very bright lights. I don't like them either. And so having almost like this home base that is easily accessible to them, for them to be able to come in, and it's just a physical change of environment to also create that physical change in mood where they can just feel more open. Things also for the future. So how do I want to phrase it? So I think it would be good to maybe do, as we do a little bit already, and it can be hard to come up with a designated schedule, but ever so often doing our own interdisciplinary team roundings of maybe one of the outpatient providers comes in addition to me rounding with the inpatient nurse practitioner, and the navigators are there just so that we can present as a unified front and they know the outpatient and the inpatient and the community are all there intervening together as a team. Yeah.
Any questions?
Any questions? Yes.
Where's the microphone?
This is in the way. How do I get this not in the way?
Is it on? Yeah? We talk about how with sickle cell, our mental health is so important. It, you know, it contributes to our pain and how we, you know, deal with everything. Do you think that it will be beneficial, along with like the patient navigators, Marla and Stephanie, to also have an actual sickle cell patient that can reach out to other patients? Because there's some things that we may be dealing with that Stephanie and Marla might not understand. So to have that person that you know have been through the same things, it might be easier to talk to.
And that's what we try to do with the peer support groups, but as mentioned earlier, it's a little hard because particularly as we're getting into the colder season, nobody wants to trek out for an hour and a half into the cold. And so I know with the PCORI study that India was referencing a little bit earlier was that part of the study is peer mentoring being measured. Unfortunately, though, we're in the controlled arm of that study, so we can't exactly, on at least the ped side, endorse and try setting up peer mentoring, but that doesn't mean on the adult side maybe we can try and figure out how to do that. So I know that when I meet with patients and I know that they have friends who are other patients, I often will encourage them in the moment to reach out. So I kind of talk about like, hey, have you talked to this person in a while? No, we just kind of fell off. I would like to reach out to them again though. Okay, well, let's do it now. Send them a quick text message and see what happens. So I still try to like encourage those relationships to happen, but in terms of having like a formal, or maybe not even formal setting, but enlisting, like, as you said, a peer support, that's still something that needs to be worked on, yeah.
Can I interject before you ask your question?
Well, mine was piggybacking off of her.
Okay, go ahead.
I'm actually one of the community health workers who has sickle cell at CHOP in Philadelphia. And what they did was they specifically hired someone with sickle cell disease, but who also had a background in case management to work with the community of young adults who have sickle cell disease for that very issue that you brought up, because there are just some things that culturally we get, having this disease that we get, and it just makes it easier navigating and connecting or engaging with our patients. But then also on the flip side, when it comes to the research aspect, we've learned that having someone who also has the illness, even if they don't disclose that they have sickle cell disease as well, the outcomes are better. You have better retention into the studies, or our clinical trials are better. So it always just looks good data-wise when you have someone who has sickle cell disease on the team, in a major capacity type of role, and not like a mentorship type of role.
So I would like to say, I think our plan in the future is to try to get something similar, whether it's partnering with Tiffany and Dion and seeing if we can get the CBOs, maybe we can help them write a grant to be able to employ somebody on that level, or through some upcoming legislation talks that we're going to be having, maybe try to put that in, not only here at VCU, but on a statewide level. And in the future, through some of this other discussions we're going to have, we are going to be expanding the behavioral health team. And so by doing that, we might be able to find somebody who has more of that. We need time. We just don't have enough time, in our day to do all. I'm not making excuses. We just don't. So to be able to find a champion there who can maybe help us figure out how to do that and how to put a proposal together, or how to make this something that would work. I remember when I was doing transition, which was a while ago, because Dr. Sisler was pregnant with her youngest. We actually went to a adult support group meeting at that time, and we had patients who signed up who said, we would love to be mentors. We would love to go into the pediatric hospitals when parents have to go to work and have to leave their kids there and be able to sit with those patients. And we want to be able to mentor younger people. Well, then we just didn't have the time, we didn't have the resources, and it kind of got pushed on the back burner. I'm not making excuses. I think that was a poor thing of us to do, but I think it's something we really need to look at. I think it's very significant. I respect what both of you have to bring to the table, and maybe we should have some conversations and try to maybe figure out what the best way is to move forward with that, because I think it is important. Yes.
Yes, just to piggyback. So I'm kind of the same. I don't have sickle cell disease, but my husband and daughter do. And so through the CBO of Maryland Sickle Cell Disease Association, that's how I came on board. I left my career of 13 years and worked part-time for MSCDA, and then worked part-time for Johns Hopkins. And it's so much when I go into a home and someone with sickle cell disease, first of all, they see someone that looks like them, and then I disclose that I'm affected, and I may not be able to 100% understand their pain, but I can tell my story or my testament, and it is a 360 when they hear that, and they open up and they tell their story, and then they're entrusting, because I'm in if you're familiar with Baltimore, going to see East Baltimore or West Baltimore, and they're like, and then coming from Hopkins, they're like, okay, well, I can see and entrust you. So just like you said, working with Dion and Tiffany, and try to get something, I think that would have really great retention rates and so on and so forth.
I agree, and I'm actually happy that you brought that back to my attention, because it's now on my to-do list for an upcoming meeting that I have, and I think it's something for us to come back and revisit. I think it's really significant, and it's like any, yeah. But you think about the HIV population, or you think about the diabetes population, they do that peer mentoring, and when Joan talks a little bit later about, I don't want to step on her parade, but when Joan talks a little bit later about community health workers' roles and responsibilities, you're going to see that we've actually put something into practice that is in the process of being published, and if it does, I think it could really help bring this movement to a whole different level, so I'm going to let her talk about that.
I have a quick question.
Yes.
It's just in terms of
the telehealth? Like, have you thought about using telehealth or incorporating that into what you're doing?
So we actually started an echo program. We are now doing echoes once a month. They started in February. 4 or 5 of us went out and got trained at the echo site out in New Mexico about a year ago. We have had, the CBOs actually do join most of the time our echoes. I don't really know how to open it up to patients, but they're welcome to do that. And we've also opened it up to providers around the state, which is how we met Teresa. And we've actually had some providers. The goal of the program really is to try to get physicians who are not dedicated hematologists, oncologists, to maybe provide sickle cell care, especially in these rural areas out there, and that we would partner with them to provide them the support that they needed with Dr. Smith, Dr. Lopato, and Caitlin and Micah, and we're making a little bit of headway. We do case presentations, we do didactics. That's the telehealth that we have. I don't think we're in the position yet to actually do true telehealth medicine. Dr. Sisler does it in the peds department. We just haven't done it on the adult side. Dr. Sisler's on a much better, and you might want to chat to that, India.
We don't do true telehealth, but we do have several outreach clinics. So we go to Fredericksburg and we're going to Clinical Heights now.
Did you mean telehealth for therapy?
No, for mental health.
Oh, no. But I think that that is, again, something to put on our ask list. I mean, if we continue to expand our program, I don't see why we can't be in the 21st century doing something that is really important and going to bat to the institution and saying this is what we need. So whoever's taking notes, we need to put that on our to-do list as well. What I would like to do then is, I'm sorry they're on separate screens, so I'm going to flip. Some of you may or may not have already met our patient navigators. Marla Brannon is a bachelor social worker who's been with us 3 or 4 years. She came to us with some really great inner city experience working with troubled youth. She is instrumental in helping to work with our population, does a really phenomenal job. And Stephanie Von Sams actually started with us back in six years. So she worked on our R18 SHIP HU program that we talked to you about and was an hourly worker for a while. And then we decided, which we'll talk about tomorrow, that that was not the best track to go on. And after some convincing, she did apply for the full-time position, and she's been with us ever since. And we just heard today that a third person has accepted our offer for another navigator, so we're really thrilled about that. And they could come up a little bit later today. They're going to tell you kind of like what they do during the day. I just want to have them maybe tell you about their experiences today. So Marla, Stephanie, please come up and. Oh, they're going to sit. You got to lower that microphone then. Lower that microphone.
Hello, I'm Stephanie Sams. I'm a patient navigator. We do day-to-day work with the patients. We go to see them when they're admitted into the hospital. We go to see them in the emergency room. They call us and tell us what their issues are, what's the problem. So we try to think out of the box. We do documentation of our assistance with the patients. There's always something new. We go out into the community and meet with them. We go to libraries, we go to their homes, we'll meet them at a restaurant, we'll go on school campuses. I've gone to funerals. We go to the housing authority, we go to the behavioral health authority with them. We go to other doctor's appointments with them. We help them get other doctor's appointments. We pretty much work with the core competencies, the basic core competencies of a community health worker: outreach, individual and community assessment, effective communication, cultural responsiveness, and mediation between the providers and the clients, education to promote healthy behavior. We enjoy working with the patients. We actually have fun with them.
Once again, I'm Marla Brennan. Our ultimate goal is to decrease ED visits and hospitalizations. So whatever that entails, that's what we do. We want to improve the quality of life of the patients. And so I often don't call them patients. You treat them as individuals. I treat them as I would want to be treated. So I have a really good rapport with all the patients. They can call anytime. Yeah, they do call, and some of them even have my personal number. Yeah. So she does. So they call all the time. There is such a plethora of what we do. I've taken them to Social Security, help renew food stamps. We put them in housing. We bought groceries. We have bought furniture to house their apartments. Just a listening ear. We've gotten cussed out and hugged at the same time. And what I'm realizing is, even though they are adults, they need a lot of tough love. And some of them don't have the skills to be adults. So that's kind of where we step in, and we do a lot of hand-holding and guide them through the process and just teach them how to advocate for themselves. So yeah, we go see them in the hospital. Yesterday I got a call, someone was in the ED and she was irate and going through it. And so sometimes, because we have that connection with the patients, I may be able to say something to them that Micah probably can't now, that Caitlin probably can't say. So it's like, you're demonstrating this, and this, you've done this, and this, so this is why you're getting treated that way. So we're able to have more of that connection, almost like that peer connection with the patients that the providers don't get to have. And it has really worked out well, I think, because I think before this program started, the doctors were kind of missing, or providers were kind of missing that middle ground between the social aspect and the health aspect. So having Stephanie and I, and now having the inpatient nurse practitioner, it brings it all together. So it paints a really good picture for the doctors to see on the outpatient side as far as providing, better care for the patients. So it's not just one thing that we do. I can go on and on.
The top 50 utilizers.
Oh, yeah.
I'd like to both mention advocacy for the patient with providers.
Well, so a lot of upfront, let me back up because Stephanie has my mind going now. So the program started, we started working with the top 50 utilizers of the hospital. The patients who cost the hospital the most money utilize the hospital the most. So I had 25 patients, Stephanie had 25 patients. We didn't always work with all 25 of those patients.
At the same time.
Right, at the same time. And I think actually now, it's been a year now, I think of my 25, I'm probably down to like 3, but the other patients that I work with are the newcomers who could potentially get on that list. So now we're working hard to keep them off of that list. You want to add anything else?
Advocacy.
Okay, so normally when we step in and push hard on the whole opioid situation, it's getting to a point where we see some things, the inpatient nurse practitioner is seeing some things, and so ultimately what I do is I talk to the patient and let them know, some things that we're seeing that we're concerned about and some potential consequences of those behaviors. And I try to encourage patients to do something. No, you may not be able to work full time, you may not be able to work part time, but you may be able to volunteer. We have like a behavioral sheet, and sometimes I'll go through, okay, what did you do at 8 o'clock? What did you do at 10 o'clock? And most of the time it's nothing. Watch TV, nothing, you know. So you could go sit at the front desk at a library and do something part-time just to get out of the house. You know, I've called patients, did you take a shower this morning? Get up and take a shower, brush your teeth. You know, just moving around sometimes helps, you know, with the pain and the anxiety. So I try to motivate patients to get up and do something, because what's happening right now is causing you to lean more so on your medications. And when that happens, we see an increase of ED visits. Some of them can be pretty irate when they come into the hospital. We go to the apartment building and we do pill counts with the patients. I've taken pictures of the actual pill boxes and, you know, sent them to the provider. And sometimes, not all the time, it's completely off. Like, how in the world did you get this many and you should have 69, but you have 6? You know, those types of things. So now that, you know, we're in the picture, it puts it on the forefront, because the providers kind of missed that piece of the information before. So now that we're in the picture, we're bringing it, we're putting it in their face. No one's lying on you. I'm counting it, you're counting it. It is what it is. So, and with having that information, it improves their care. I mean, it may save their life, which is, you know, the ultimate goal. So, yeah. You want to add anything else?
We also, those are not the majority of our patients. So we have like 600 patients, and we work with the top 50 highest utilizers. Oh, I'm sorry. I don't like that picture. So we work with the top 50 highest utilizers, and the goal is to cut costs of the hospital. Everybody is not the same. We don't have all we do different things with different people. Everybody is not always coming up short with their medication. Sometimes we do have to advocate with the provider that the patient needs something else. There's something else that the patient does need. This is not working well for them. This is what they're saying is the problem. This is what they're saying they're missing. We will advocate for them with the providers. So if we think they're not getting, it's not always, look, you're messing up your pills. It's not always that. So.
So I have a question. I know that you guys mentioned that, or one of you guys mentioned that most of them don't have the skills to be adults. And then I know that, thanks. Hello. I know that for transition, we were mentioning earlier that that age is what, 18 at the time, and now it's, you know, because of logistical issues. What age do you guys think would be a good transitional age compared, you know, in conjunction with what you guys are doing now?
Having children from the age of 32 to 19, that's different for everybody, whether you have sickle cell or not. Some children take a little longer than others.
But I want to add that you have to remember, we work with the most difficult patients, and it's only a handful, give or take, 2 handfuls, give or take. But so there are a lot of patients who are thriving, doing well, working full time. They may pop into the hospital, we don't even know their name. Who is this person? Let me go say hi, that kind of thing. So we work with a smaller group of the sickle cell population. So, like I said, there are many patients who are doing well, and like I said, I don't even know who they are. We have transition patients that I met when they first transitioned, and I don't think he's been in the hospital 1 time. So, like you said, it just depends on the age of
the individual.
Right.
What do you do for symptoms of the sickle cell patients, like there was no program of activities with the community-based motivation. I took on my together there, but to include the siblings so that they could understand and realize without jealousy, because you're in the hospital a lot, you're spending a lot of time and attention on the sick one. So the siblings that don't have to deal with, you know, what do you do to educate and include them into that scenario?
We're working with the adults, so we don't have the children that might not have a complete understanding. But we have provided case management services to family members to help the patient work, you know, their family to work well. We have provided services to siblings, to caregivers. We've helped family members also.
So I'm a community health worker at Johns Hopkins Hospital, so I can definitely relate to some of the things that you guys do for your patients. So my question is specific to a patient you may get that they want you to work with for whatever reason, but to keep them, you know, they're utilizing the ED frequently. Well, let me back up. What do you do with the patient that you get that just does not want it here? Right? And you work with them because I have some of those patients, like I've been working with patients for a long time, you like want to pull your hair out, right? Because just like you said, the patients want to fight you and hug you. I want to strangle and hug my patients at the same time. But I'm like, stop, take your medicine, go to your appointment, right? So what do you do with those patients? How do you address that? And is there like a stopping point where you say we need additional assistance here because this isn't working, just having a navigator?
We actually have more resources now. We have more resources to pull from, and we try to think out of the box. We do a lot of hand holding, and like Marla said, go ahead, tough love.
Yeah, tough love. But I mean, we have to remember they are adults, so we can't make them do anything. So I think in the beginning, like I said, we do a lot of hand holding, building up the trust, that kind of thing. But it does get to a point where you are beyond me. You need to talk to Taylor. Well, I don't want to talk to Taylor. Okay, well, let's find somebody else in the community for you to talk to. So I've gone on the back of the insurance card, the behavioral health, and I have pulled up, you know, providers that they could potentially talk to. They may or may not want to do that. So then, you know, you keep going, but then it gets to a point where, okay, it's on you now. I'm here for you. I will show up at the doctor's appointments. Hey, how you doing? You need anything? If you're admitted, I come in, talk to you, how you doing? And I'll reiterate, you know, and encourage what I feel like they need. But, I mean, you can't make them do anything, so.
That's part of the frustration.
Right. But, I mean, I can only think of one person that comes to mind, but because most people, they want that support. They may not have a good relationship with their family or whatever's going on. So to have someone that I can call maybe at 9 o'clock at night and she might answer and entertain me for a little while. I mean, who wouldn't want that? So.
Okay. Really wanted to touch a few points. So someone mentioned earlier that some patients may have a death complex or feel like, or have been told, you know, you're not going to make it past this age, and, you know, maybe you should be more careful and this, that. But, okay, so we also speak on transitioning, like what's the perfect age to transition. If that patient feels like I may not reach this age, this transitional age, then I may not, or it may not be necessary for me to seek a physician, a primary care doctor, because I may not reach that age. So I believe transition should happen earlier. I know you guys did the whole, you know, if the child is 18, they should go back and try to advocate for themselves during these hospital visits, but you said that did not work. I feel like, okay, so my experience with that is when I was younger, my mother did speak more for me. So I didn't know how to advocate for myself. I didn't even want to speak to other people. I had like this selective mutism type of thing because I felt like people did not hear me, even if I did speak. Like maybe this person who is saying the exact same thing that I'm going to say is going to be conveyed better or perceived better or digested because, you know, I'm not sure they have a voice and I don't. So maybe not, you know, having children who are 18, you know, just go back by themselves and, you know, do the process by themselves because they've never had that. But having these conversations with a parent, I've interacted with several parents and they may not understand the complexity of the disease, how it has several, you know, different layers, or how all these different factors affect that individual. So you got to understand, of course, culturally, how all of these resources provided to, you know, these other chronic diseases may not have been provided to, you know, those who suffer with sickle cell disease. So I would definitely target the parent, educate the child that does not have sickle cell disease, because honestly, it's nothing to be jealous about. It's a lot of education that needs to happen, psychoeducation, because if you aren't aware of these things, you can't combat them. But definitely start earlier for transitioning, even if you can't just, you know, address that child, address the parent, so the parent can, you know, guide that child to these decisions.
We're going to take one more question. I know you've been waiting.
So we talked a lot about patient navigators' interactions with the patients themselves. But what I'm curious about is there's lots of different names for patient navigators. In my institution, in a pediatric setting, I'm a health advocate and care coordinator. And what I'm curious about is we know that VCU is an outlier. So when you are having conversations with other providers outside of the sickle cell team regarding your clients or your patients, how do you navigate when your voice is not heard or respected in the same way? Or if they are questioning your approach, which may be more culturally sensitive. Now, I'm from Minnesota, so a room don't look like this at all. And so I am often defending a more culturally centered approach that they really, I'm not expecting them to understand, and I'm not going to, in that moment, break it all the way down, because it's not my job in that moment. So how do you navigate those spaces?
Well, okay.
The American Society for Hematology is aware that that space exists. So what it has decided to do is to award programs around the country money and time and training to get a program established that has a provider champion, maybe a business person, someone to actually provide the care, turn the institution around. You're talking about institutional culture. Turn the institutional culture around to become friendly towards sickle cell disease. We cannot do what you just said, all the talking in the world. I could give you incident after incident where I talked to a pharmacist, I talked to a doctor, and basically they said, screw you. My culture here, I would speak of a city to our northwest that said, well, you people down there. I was going, and this was a pharmacist not willing to fill a prescription I wrote. And I thought, okay, thank you very much. Because I was not going to change that person's heart or mind. So I think that's the answer. You have to start with the institutional culture. You got to have a program in place where there's a champion locally who has credibility, and that person might be able to change hearts and minds.
I will also say when we run into that problem, we take it to our providers, because providers listen to providers better. And Micah over here is a champion at that. We always take our problems to her like that. And she's real good at getting in somebody's ear and talking to them. She has a lot of success with that.
I'd like to clarify, the word I say, the word jealousy, is because when children with sickle cell spend a lot of time in the hospital. I know it's nothing to be jealous of, but you're basically there with the sick kids, and in a child's perspective, you're not, in a well child's perspective, you're just not there with them like you are with them when they're getting all the attention. And also, I would like to say, we do a support group at EMS, and we did a vision board. And so if we realize we try to emphasize to the patients about mind, body, and soul. So we're trying to emphasize to the patients, look at, you do have a future. And write your dreams, your visions, your wants and hopes down. Do a vision board. And we had licensed clinical social workers who come in and, explain that this was to the adult patients. This was not to children who really need something like that to latch on to as well. More so. But when you become in a depressed state or an oppressed state, or you've been so far belittled, it's hard. And relying on your parent to speak for you, it's hard. But those are some of the tools that we're trying to get across to patients and some of their family members. Keep faith, keep hope, keep dreaming. Life is worth living. Celebrate life.
Lessons of faith.
All right, we need to move on now to the remaining of our team members here. I want to introduce you to Caitlin McManus, our outpatient nurse practitioner. And again, they're not on the same screen, and I think now we're frozen. Daniel? And Micah Furlis, who's our inpatient nurse practitioner. I just want them to share a little bit about what their day-to-day duties and responsibilities are to the patients and how we all come together to work with them on a clinical level. So Micah and Caitlin?
Hi there. Again, I'm Caitlin McManus. I work on the outpatient side. So I'm in the clinic 5 days a week. I'm primarily seeing patients for their routine visits, whether that be every week, whether that be every month, every 3 months. It kind of depends on the patient and depends on how they're doing. I would say me and Micah probably speak at least once or twice a day, if not more, kind of depending. So we're constantly in contact. Who's in the ED, who's doing well, who's not doing well. Is someone paging? So we keep in contact very frequently throughout the day, just to make sure we're all on the same page. So that's kind of my rundown. Huh? And on group texts with our patient navigators and Taylor and Shirley. So
there's two
yes.
group texts now. There's a provider one and then a team one.
A team one.
Yeah.
Yes. So we're constantly buzzing about.
No, we try to leave him out. I am the inpatient nurse practitioner. I try to catch them in the ED if they get here. I'm Monday through Friday as well, so during the day. I get a lot of pages first thing in the morning for anybody who came in overnight to see if there's refills or do they need to be admitted or can I come touch base with them. And then I try to see everybody who's inpatient, providing the census isn't too high that day. There's only one of me and sometimes there's 20 some of them. But I try to at least get into everybody's chart and make sure that their needs are met, making sure that they're getting adequate pain control. Do they need transfusions? Are we screening for other complications? And touching base with the teams. Do they need anything to better manage this patient's pain? Do they need anything for coordination? Hence me and Caitlin talking, do they need an appointment tomorrow? I try to touch base with the nurses that are taking care of these patients to make sure there's no miscommunication on how to give these opiates and how we need to dose them and time them. ER nurses for the same reason. And a lot of it, I'm in touch with the patient navigators constantly. Who called you overnight? Who needs something? Who's running out of medicine? Did we do that pill count this week? Et cetera, et cetera. I also take the team pager during the day, so any of the urgent issues that come up, I'm usually one of the first ones to know about them. Hence the group text. I can reach out to the docs or Caitlin or the team if I need help with anything, with coordinating anything. And I think I'm affectionately, or at least I think it's affectionately called the Hey Girl. Hey, how are you today? That's it.
You said you work Monday through Friday?
Yeah.
So do you have like the text sheet for emergencies that may take place over the weekend when patients are in-house?
So we share sort of the on-call responsibilities, the 4 providers, the 2 doctors and me and Caitlin. So there is somebody available after hours if something needs. We just rotate it. Yeah.
How do you become a patient and affiliated with your, is it referrals, walk-ins?
You mean like new patients to the clinic? Yeah, they just will call and ask for an appointment with the sickle cell clinic, or if they're admitted to the inpatient side because they're transferring their care, they moved to Richmond, they didn't know who to call, they landed in our ER, we'll just get them set up with a clinic appointment. Yeah, it can go either way. Okay, sure.
Okay, so we're winding down our team, but believe me, the last 2 people are just as important as the ones ahead of time. When our program started a year and a half ago, one of the main contributors to our overall expense was because patients could not get prior authorizations and ended up in the emergency department and thus were admitted. So we developed a position called the prior authorization specialist position. This is Austin. Austin gets numerous applause. And I'd like to say he officially becomes full-time October 7th. This is Austin.
So I'm responsible for prior authorization of opioid medication. That's what I specialize in, is opioid medication. Like it was brought out earlier in Dr. Lopato's talk, we unfortunately are in that climate, so they as a department expected that prior authorizations would be a huge part of prescribing opioid medications, and that's where I come in. So I'm able to speak to the patient's insurance companies, provide them with whatever information that they need for the authorization of any medications. I also keep in close contact with the providers just to give them updates on any outcomes and also to get information from them through EMR. We also have me document some of that information in our electronic record-keeping system, RegCap, here at VCU. Right, yeah. So part of what I do, and the main goal of my position is to decrease that turnaround time from the script leaving Dr. Smith's hand to the patient to when they get to the pharmacy and turn it in. Unfortunately, we have patients and patients' parents in the building. We know that when you give the script to the pharmacist, unfortunately, that's when you learn that you have a rejection on that prescription. So that puts you in a time crunch. During that time, you're not going to have any medication. You're more probable to go into the emergency room and seek care there instead of handling that crisis at home. And that's where I come in, so to speed up that determination.
And one of the things that Austin isn't kind of giving himself credit for is he's also been able to establish, unless the medication's been changed, when the prior authorization will be coming due. And so we now have like an Excel spreadsheet, and we kind of track when that medication may be coming due. Now, we don't 100% are not successful, but we're pretty successful now. I mean, we are able to pretty much, between what he has done and the rest of the team, hopefully are able to capture a PA before, it ends up being hospitalization. So this is a really critical role. I don't think we really realized how bad it was until the person who had been doing it on a volunteer basis for a year in our clinic came to us and said, I can't do this anymore. I'm like working on weekends, I'm not getting paid. And we're like, what are you talking about? We didn't even know this person was doing this job. So it all came down to, again, going to bat, fighting for a position. We were able to get it hourly, and after a year, been able to show how much his role has been improving our overall length of stay, all the normal stuff we've been talking about, and now we've been able to get him hired full time. So we're very appreciative of the role that he plays, and he works really well with all of us, and we're very blessed to have him. And I'd like to introduce to you our administrative assistant, Donna. Donna's been over there. Donna, you have to come up. Come up, Donna. Yeah, Donna, you got to tell them what you do. You don't get excused. So when Donna came to us, we had not had a dedicated, I know you think like, it's an admin assistant, like, how significant can that role be? Oh, let me tell you. So not only did she take over managing Dr. Smith's calendar, which in itself was a full-time job that I had to do, but she also has taken on some ownership of helping the patient. So I just want her to kind of tell you a little bit about what she's doing to kind of help with that, and again, how it's kind of keeping patients from being readmitted to the hospital.
I contact the patients every Friday and remind them of their appointments. A lot of times when I get them on the phone, they want to reschedule, cancel, whatever, but I get in touch with all of them, whether they show up or not. That's up to them, but they were reminded of their call, and that is to try to cut back on no-shows. That is,
and then she does that other 5% of everything that's not in your job description.
yes, admin assistant stuff.
Yeah.
Just
Thanks, Donna. We're going to go ahead and get on to some giveaways again, but although he's not here, Al Dunn is our department administrator. And without Al going to bat for us to hire administration, some of the things that we've just been telling you that we had to fight for probably would not have happened. So I know he was going to try to come here, tell you a little bit about his role in this, but obviously he runs an entire division of internal medicine. So we are very grateful to have him on our team, and he's a very big advocate for us. Real quickly, just kind of wrapping this up, we also have very other teams that we've been able to design. Our oversight team, which is our team that we have every Tuesday morning for about an hour and a half, that help put that DMAIC process together. We get back together, we review our different smaller committees that we have. We talk about any urgent matters. She gives us updates on our inpatient team, which Justin, I believe, is a part of, which is a group of hospitalists and nurses that got together even before the medical home because they felt such a passion for the sickle cell population. So they have one designated unit right now in the hospital where we try to get as many of our patients in as we can. Justin's one of our champions. He really enjoys taking care of them and has really kind of taken on as a personal journey like the rest of us have. So we're very grateful for their teams. The other team that's really important is we have been able to establish stakeholders with our emergency department. I cannot stress to you enough how much of a difference that this has made. And if any of you can join our Echo on October 2nd, where you're going to replay our, hopefully, our ER doc is back again, but if not, Mike is there. We're going to let you know how we went from, oh my God, what are we going to do with these doctors because they don't want to listen to us, to a relationship that has really been a very powerful one, and we communicate with them regularly, and we are all on the same page. We have treatment plans. They know the patients. We converse. Micah meets with them. It's been just great. And then our ambulatory team, we don't meet as often now because we're trying to get an infusion center together, but we were trying to do monthly meetings and dealing with any outpatient clinic issues that might have been going on, and those will resume once our infusion team is done. So I know we rattled on. Joan's giving me the sign. I'm about half hour overdue, but I think it's really important we have our giveaway. So here we go. Probably not do the break thing again.
No. Just, I'll see if I can do 15 of them or something like that. Go for it.
Who hasn't won anything yet? Okay, hopefully your name will come up. Francine? Where'd Francine go? There she is.
Oh, you want to do it?
Oh, go ahead.
Okay, I was just going to run quick.
Emmanuel? I don't think he's here.
He's not here?
No.
Okay.
Oh, Tiffany won yesterday. Your name just doesn't go away. I don't know. I don't know what's wrong with it.
Oh, his name. Okay.
Ron won yesterday. Judy?
She did yesterday too.
Yeah.
Yeah.
Oh, you won? All right, one more. Last one for this session.
That's one, no more?
LaShonda? Oh, you won?
You won? So one more?
I don't know. They just don't want your names to go away. Yay! Okay, Jill. That's it. All right, well, we're going to take a short break. If we could come back at 3:30, snacks are out there with some drinks. If you're not done, can you bring them back in since we're kind of running behind a little bit?